have this conversation within a safe space to share your thoughts and ideas. I don't always am an expert in this field, however, as a medical student that's been in the Southwest for the past 5 years, as a woman myself and as a woman of colour myself, I think lived experience trumps everything. And so when I talk about the experiences of the women in this presentation, as well as the experiences you may have come across, I think it's really important to understand that this is an ongoing discussion. We're very much not there in terms of solutions to women's inequalities, and so conversations like this are so important. So I just want to say huge thank you and round of applause to yourself. There. So the way that this event will work is I'll go over a presentation with a few stats, a few lived experiences, and then what we will be doing is a bit of rejigging where we'll turn this into a discussion circle where you'll be able to share your thoughts, your ideas. If you do find anything particularly triggering, a big disclaimer, I'll be talking about things like gender-based violence, as well as discrimination against race and gender themselves. So if you do feel like you need to step out for a moment, please don't feel like you need to justify yourself or anything, please do so. So, this is me, and it was very nice to say Dr. Naabil Khan, but I will be a doctor in July. I will not be doing another doctor currently, but I'm an incoming resident doctor. I'll be based in Kent, which is quite sad because I'll be quite far away from the Southwest, but definitely be visiting again. But it's just great to be here today, and I discovered the IW went through the CEDAW event itself. So I was actually on my general practice rotation, and Noor reached out and said, we've got this event going on at Truro Museum. Would you like to get involved, or would you like to contribute because you come from a healthcare background? And the conversations that were born from that event was so interesting. It was so nice to see not just medics talking about women's health and not just medics talking about women in general. It was people from all walks of life, all parts of society. And so that's really where the idea was born from. It's the idea of interdisciplinary thinking and sometimes transdisciplinary thinking, really taking advantage of the skill sets that we provide to society and combining them, not just medics, not just lawyers, not just engineers. So thank you so much again for being here. So what we're going to start off with is just a bit of a pop quiz. You can basically just shout out if you like. Thankfully, we have quite a close-knit group, so if you feel like you want to share, please do so. But I've got a couple of questions just to kick us off and start our conversation. The questions in this will be covered again throughout the presentation, but I thought it'd be nice to gauge where we're standing at the moment with regards to our general knowledge about women's health in general. So, true or false? Women experience heart attacks in exactly the same way as men.
False.
Perfect. You know that? Yeah, false. And we'll be covering that in more depth later on. But it's a commonly known misconception that women and men experience heart attacks the exact same way in their pathologies, the exact same work from the exact same mechanism. It's really important that as women and as men, there aren't any men in the room today, but as I spoke to Deborah a couple of weeks ago, we were saying that we need more men in this room to actually understand the misconceptions that are present within medical education and medical healthcare, as well as women's health, to understand that there are differences. And so, for example, something like stomach pain could present as a heart attack in women, or chest pain, or back pain, not just that crushing chest pain radiating to the left-hand side. That's not what's commonly seen in women. Next question. Women are much less likely to receive bystander CPR, so cardiopulmonary resuscitation, than men. How much by? So, and 50% less likely, 22%, 27%, or 56%? C. So we've got C's and then we've got 1D. So the answer is 27%. So they're 27% less likely to receive CPR. We'll be going into the reasons for that later. How much longer is the gap in life expectancy between the most and least deprived women in the UK? So you've got 3.5 years, 5.5 years, 8.4 years, or 12 years. Everyone's saying 12 years. It's 8.4 years. So not as much as 12 years, but still really not good. And when we talk about high levels and low levels of deprivation, we're looking at socioeconomic index, we're looking at things like housing, employment, income. So when we talk about deprivation, that's what we mean. And so this is what I'll be covering today. As I know from reading up on your bios as well, a lot of people here today have extensive experience in women's health. So if there's any point in which you'd like to contribute or you'd like to say something that I may not have mentioned, please feel free to do so. This is a safe space, and I'm here to learn as much as you guys are here to learn as well. So that'd be great. So to start off with, why does this topic matter? I think it's a very self-explanatory answer, but we'll be going into that. The current state of women's health in the UK, what is the key medicine, pain management, gender differences in CPR and emergency care, as well as women's health across diverse contexts and cultural and socioeconomic backgrounds. I think that last point is really, really important, especially within the IWM context, because a big part of IWM is the intersectionality of not only women, but women from different races, different ethnicities, different genders, different religions. So I think it's really, really important that we do cover that as well within this context. And then we'll have around 30 to 40 minute discussion. We said 20 to 30 minutes, but I'm sure it'll last longer than that. We'll have a discussion about what your thoughts and feelings are about women's health and what you'd like to see in the future. So, as we know, women's health has been institutionally and structurally under-prioritised. I speak from experience. As a woman in healthcare myself, I've seen time and time again within not only education, but within clinical practice, how women's health is, for the most part, swept under the carpet. And it's not only just women's health, it's health around certain ethnic groups, it's health around disabilities, it's health around a lot of, in medicine's minds, minoritized groups. However, that's not the case when it comes to women. We are 51% of the population. So when you see articles like this, you do end up thinking to yourself, how come we are falling so far behind when it comes to women's health and prioritisation, when we make up 51% of the population, and so many of these stories and issues happen day in, day out, not only instigated by men, but instigated by other women as well. So I think it's really important that we look at our own lived experiences, as well as articles like Time. I definitely recommend giving this a read, but it essentially spans from ancient civilizations to now, and how gender roles essentially have been systemically integrated within our society, and how women are still, again, paying the price today. We've seen again and again the disparities amongst Black mothers, for example, amongst women when they're talking about pain, amongst dynamics within general practice in primary care, so in GPs or in secondary care in hospital. We're still paying the price today. And again, women's health has historically been under-prioritised. We can see it not only within our history, but within our funding, for example. So a Nature review in bioengineering found that funding research on women's health was systemically under-resourced and underfunded, which had meant that drug testing, for example, and testing on certain medications was not used on women, but actually just used on the majority male cohort, because the funding was there for that male cohort to experience those trials. As a result, you have more side effects in women when they were actually experiencing the course of that medication. Women's health is chronically underfunded, according to Linda French-Gibbs, who is a big philanthropist and contributes to so many different charities. But the very idea that she's looking at the underrepresentation and the prioritisation of women's health shows that there is a big, big gap that we need to plug. Women's health is a neglected human right. We're talking about women's health just in the UK, and we've seen the disparities and the gaps. I can't even imagine what it's like in, for example, countries that potentially don't have those protected laws around women, protected laws around healthcare in general. My background is from Kenya and Pakistan. I was born here, but when I look at those two countries and I see the disparities, and just the idea that you can't say words like breasts or genitals, tummies, yes. Yeah, so it's important to brush up through, for example, people like Melinda Gates, who, as you noticed, is the philanthropist, but also a billionaire who has more money than we have.
Caused a lot of damage.
Yeah.
In different countries.
Yeah, so it's really important that we actually look at this topic within a critical landscape as well. People like Melinda Gates, for example, have been privileged enough to be in a country and in countries that have high levels of development as well as income as well. So actually looking at her impact within countries like developing countries, for example, like Kenya and Pakistan, it's really important to actually say what's going on here, and are we actually impacting women's health globally on a beneficial scale, or are we actually just looking at it as our relativism as someone from the UK, someone from the US? So yeah, it's a really good point that you brought up. When we look at the women's health strategy, which I'll be covering later on today, we see the underfocus and the fact that a lot of people don't actually even know that the women's health strategy exists in general. For us within this space, it might be because that we do know it exists. Either you've worked within it, or you've got education that's surrounded by it. or you've done your own pre-reading, but the general population, more than half of the general UK population, haven't even heard of the women's health strategy. So again, it shows what's being prioritised, what's being valued, what's being covered within the media. And then finally, we have the American Association looking at why we don't say this about women's health. And again, it focuses on clinical trials, the fact that clinical trials mainly focus on male perspective. When we're talking about, for example, period products, blood was at use until incredibly recently. And when you think about it in the grand scheme of things, you've got millions and millions and millions of women using these products, but the wrong resources and the wrong testing subjects are being used to see the efficacy of these different devices. So it's really, really important that we not only acknowledge it, but we think critically about these different articles. When we look at it, we don't just read it and move on. We actually go, okay, what can I do to help? Or who can I contact to try and help? Or what can I do with my establishment to try and raise awareness about these dynamics, about these inequalities? And so I want to do a very, very, very brief history of women's health in general, which again, we could be here for years, but I'd like to pick up on a term that has been thrown about around for, well, not even centuries, since ancient civilization was created, the idea of hysteria. You might have seen it before, you might have heard men and women use it as a throwaway term, they're being hysterical. Hysteria. Sorry? Yes, exactly. Just the archetype of the hysterical woman. It's ingrained within misogyny. It's the idea that the uterus was the reason for emotional, psychological, and physical problems. It didn't pathologize women's health. It essentially said the uterus is the cause for you being depressed. The uterus is the cause for you having these convulsions. The uterus is the cause for you to not integrate yourself within society. And again, it recognises a part of a woman's body that they have no control over. We all have uteruses, and the idea that that's being weaponised to justify the behaviour that's a behaviour made against women. For example, in this case here, with this picture, I think everybody she was experiencing levels of depression and anxiety as well as PTSD, whereas the physicians in this picture thought it was hysteria, and as a result would try and treat it in their own way. Hysteria itself originates back into ancient civilizations such as Egypt and Greek physicians. They described it as the Roman uterus. You had some physicians saying that the uterus was actually moving around the body, which was causing this imbalance in women. Other physicians said that it was caused by the build-up of fluids within the woman's body. So when they talked about menstruation, they actually, they weaponized it in a way to justify the violence and the oppression enacted against women, for example. What was really interesting, however, is when I was looking at this history, there have been gynecological texts and women's health texts that do state back, that do harken back to ancient Egypt. The first known gynecological text was the Kahu gynecological papyrus in 1825 BC in ancient Egypt. And so when I was reading through that papyrus, it did focus on women's health, but the misogyny, ingrained oppression and bias against women within those systems harken back to such ancient civilizations that you look at it today and you think, have we made any progress? Have we actually learned from these ancient civilizations? How has it impacted the way we see women today? Hysteria itself has been taken off the index of mental health. If you look at the book itself, it's been taken off the terminology because it was ingrained in misogyny. But again, we use the word hysteria so often within society, either colloquially or using it as a throwaway term. We do have to ask ourselves, how much have we grown? And so I think it's really important to address that. One other shocking thing I found with hysteria is that the treatments for it included some incredibly oppressive methods. So some of the treatments included marriage, sexual intercourse, pregnancy, and even manual stimulation. So trigger warning for anyone. Physicians actually thought that if a woman got married and then had marital sex with her husband, it would release the fluids within their body. It would try and fix this roaming uterus, and they wouldn't experience hysteria anymore. Manual stimulation itself meant that physicians manually they stimulated the reproductive organs to try and produce an orgasm, for example, and they thought that was a solution to hysteria itself. Incredibly unethical. But this is what this is what my point is, this historic and systemic oppression of women that have been pathologized by saying it's just the uterus that's causing it.
Kind of feels like women who are being sexually abused whilst the ones that are really vulnerable point in their lives.
Yeah, that's exactly it. It's the idea that you've got these men who are weaponizing these things that are completely out of women's control as a form of coercion, as a form of violence, and as a form of oppression. And so looking at this history, it was hard to do this reading, but I can't even imagine how hard it was for the women experiencing it themselves. So I think it's so important that we actually look at these terms. We challenge it when we see it within society, not just within the medical spaces, but if we're at work, for example, and someone's saying you're being hysterical, I've had that then said to me multiple times, and just thought, how archaic is that? The fact that we're still using hysteria as a form of insult or as a form of a description. So then, if we move on to devices that are used within, I've got a few faces there. But if we look at the devices used within gynecological health, for example, speculums, I don't want to assume, but I assume most people in the room have either interacted with speculums, have had a speculum put into them, or have seen someone have a speculum put into them. But speculums amaze me, not in a good way. As a medical student, when I look at speculums, I think to myself, how have we not grown from the devices that we used as far back as Pompeii? So in 79 AD, Roman physicians were actually found to be using speculums. Those speculum devices have not changed that much from 79 AD to the 1840s, where you had Dr. J. Marion Sims. He was a renowned physician. He was known as the father of gynecology, which the term in itself is quite ironic. He used speculums to perform experimental procedures on enslaved black women, for example. So again, another example of historical violence and oppression using the devices that we use today within women's health. And we found that, what I found within my reading, that second wave feminists actually argued that the idea of speculums took away women's bodily autonomy. The idea of putting something cold and plastic or something cold and metal into a woman in order to investigate any pathology they were experiencing was a way of, medically, clinically, and systematically ridding themselves of their autonomy, their bodily autonomy. So alternatives have been picked up. However, as we know, again, for example, with smear tests, you still need to use speculums. When we're doing things like HPV testing, you still need to use speculums. But other examples have been used of self-sampling, as well as caloscopes, which are small cameras that you can use instead of speculums themselves. But if you look at these images here, these are the ones that were found in the 1800s. They don't look vastly different from the speculums that we're using today. And I think that is a testament to how we're valuing women's health. The fact that we don't feel the need to change the devices that we're using to rid women of any pathology, but also ridding them of their personal autonomy to say, no, I don't want this inside of me, or I would like something alternative when we're testing out any sort of pathology or any sort of illness, really speaks to how we prioritize women's health in general. And we can't talk about women's health without talking about the impact of female physicians within women's health, within that space,
So if we go for enemy, if we go for a smear test, and we don't want this thing, what do we say? Because it doesn't seem to be like they don't offer, they don't say, is that okay if I use that, or would you rather they just don't say anything?
Unfortunately, I think with smear tests, for example, because the normalised test has been using speculums, I think for the most part it's just about advocating for yourself and saying, I really just can't handle speculum being put inside. They sometimes give alternatives like smaller ones. That means it causes less pain, or potentially giving you more analgesia or more pain relief. That's what I've had to do for myself. I don't mind sharing this from personal experience, but I can't handle bigger speculums, for example. And so actually I had to advocate for myself, saying I need something smaller. I need the additional pain relief. I need someone in the room with me. Just advocating for yourself, I think, is my biggest advice. And sometimes when you have physicians or when you have student doctors, as I once was, saying, no, we need to do it this way. It's sometimes just taking a step back, saying, I am the patient, I have autonomy here. So that's what I would recommend, really. I think in terms of alternatives for speculum, because it hasn't been normalised within a lot of clinical practice, and a lot of them use they use standardised clinical practice themselves. It's harder to use alternative devices, but I think it's just about creating the environment that's comfortable for you if you do really need to get that smear test done. And again, I would definitely say do get smear tests done, do get these checkups done, because again, they do save lives. It's unfortunate that the way in which we use speculums and the way in which speculums are still structured and how uncomfortable they are hasn't changed. But I think that's why we need community voices, we need clinicians, we need patients, we need community members saying there must be an alternative way. We need the funding to try and get some research into alternatives. So that's what I would say. Sorry for this very waffly answer.
Especially for young women or girls even, because once you've given birth, I suppose you don't feel like so really threatened by this kind of stuff. But if it's your first one, you might feel like, what? You know, it's just like, it's so daunting, I think. And I think we don't see it as, because we've been through since a young age, and we've taken it as, oh yeah, it's normal, we just go for a smear test and that's what it's done. I think we've not had as young women or girls to say, because I suppose we pass it down from our mothers and grandmothers done your smear test, which is great.
Yeah.
In what condition is never the question, is it?
Exactly. I think you bring up a really good point about generational acceptance as well. Just the fact that our mothers did it, or our grandmothers had it done to them, means that it's okay for being done to us. I use the word normalising a lot, but I think the word that should be used is usualising.
I don't even think it's really talked about.
No.
Even with mothers and daughters.
No, exactly.
I don't remember having that at all. Did you have that at all?
Yeah.
It's like it's a bit.
It does feel like it's big, especially within certain cultural contexts as well. I think, like you said, you may have had a conversation where another family may not have had a conversation, but I think that's why spaces like this are so important, because you yourself may have daughters you might know, you may have family members who are female, or have men who want to talk to their daughters about it, or their female family members. So actually saying, let's first acknowledge it, like you said, if it's not even talked about, the idea of just saying speculum, or the idea of just saying cervical cancer, or HPV is something taboo within your space. It's time to break that and break that cycle.
Can I just say, it is being educated. There is an education program in schools around menstrual health, around cervical screening for young girls, and within that is around the right that people are entitled to pay for these procedures. There needs to be a lot more education across multiple generations, but that actually that work is happening with young people. Yeah.
Also, boys need to be included, and like you said, it's a shame that obviously it might not be a topic that anyone feels on, because they might not feel like they are welcome, I don't know. But yeah, they can be boys
I think always they are taught, and they have to have lessons together, to the girls and the partner boys to have lessons with them. So, but they do learn about mental health in school.
I think like you said, there is menstrual health lessons being like PSHE, for example. They do include things like asking for that pain relief, which is what I'm saying. Empowerment, that's the most important part.
Okay, so it's happening in lessons, or is it happening in the doctor's surgery when girls who don't go to school need?
It's so much better now than it used to be years ago. Now,
It's absolutely awful.
now the nurses trying to make me feel at ease, they take their time, you're not rushed. And I think back to years and years ago, where you just went in, had it done to you, and it was awful.
Yeah.
Now the approach is much more gentle and observing of you and your dignity.
Yeah, and all of the points are incredibly
I
valid.
just think it should be mandatory for every woman, not just young girls, that when they go in, they deliver the information that they can advocate for themselves. Because lots of women don't advocate for themselves, they don't have the support, the knowledge, the education, the confidence.
Yeah.
So actually, I don't really care that it's happening sometimes, somewhere. It needs to be happening in every doctor's surgery, and women need to have a consultation about how the work needs to be done.
Well, yeah, no, that's exactly the point. I think with the inclusion of things like the British Medical Association, they've actually got a steering group that focuses on women's health, and they're trying to integrate the same education we get in primary school and secondary school into medical school itself. It seems like there's a huge gap where you get the teaching in, for example, primary and secondary school about what to ask for, but at that stage you need it ingrained within you. There are so many studies that have said year-long longitudinal education is so much more effective than that one-off PSHE session or that one-off social studies session. And from personal experience within the medical education space, we don't get that teaching. So you're completely correct. The fact that we don't normalise patient advocacy, we don't normalise stopping before we're about to give a specimen and saying, how do you feel?
Into an appointment armed with all her knowledge and you're like, wow, this is what I want, this is how I want it to be done. It's not going to happen, it's so embarrassing for them.
I think the issue is culture, and it's the cultural background that we place on medicine. It's society as well. It's how we address women's health in general. I think that's why next generations of physicians and current physicians at the moment, we're in that space where I'm involved in that space where we talk about, for example, racial inequities within medicine. And you've got consultants, for example, or registrars who have been there for years who don't feel like they need to change their behaviour. But then you have younger doctors or you have younger nurses who actually say, no, we need to start critically thinking and we need to start asking patients and we need to create that space for patients to feel comfortable.
I don't want to minimise what happens to women during sexual assaults, but I'm sure they have a very in-depth consultation before they take a procedure like that. And I just feel that maybe all women should be given the same kind of treatment so then it's fair. Do you know what I mean?
Yeah, I get what you mean. I think when it comes to things like assault, for example, I've got a family member who works in the assault sector of like forensic law and things like that. She says that essentially it's a lot of time and it's a lot of funding that's required for each individual exam, which is completely necessary, especially in the cases of assault. It's just harder to implement that within every woman because of all the funding and all the resources. But then that begs the question: where's our funding going when it comes to women's health? Should we start directing it towards more in-depth consultation?
Minimise and say it's the same thing at all. It's just funny how. Do you know what I mean?
Yeah. Yeah, no, I completely get what you mean. And asking those questions and actually saying, why aren't we doing something differently, is key to development.
Because clearly they've had to work around that to make it more comfortable for women.
Mm-hmm. Yeah, no, exactly. But I think what's important is education within our next generation of physicians, physicians, nurses, allied healthcare professionals, as well as patients actually saying, you are empowered, you are the patient, you are the person who is steering this conversation instead of this paternalistic, doctor knows best. Yeah.
I was going to say, you also need to do some work on trying to talk about our bodies as just normalising its body rather than making it a sexual thing.
Mm-hmm.
But you know, with these tests, like, let's give a test for cancer, should be really normal, like, body on here.
Yeah.
Oh, sorry, that's
It's been advancing on that. I had to have a very intimate surgical intervention recently. It wasn't planned at all, and I had to go I went for a check, and they said, "Oh, tomorrow morning you need to come back. We need to do that." And I thought, okay, they were all women nurses, and I just I thought, right, okay, I'll have to do that. I'll do it. And then I came, and then they were really nice and stuff. And then I came to the operation theatre, I don't know how you call that.
Mm-hmm.
And then they were all girls, like big girls. They were all round, 5 of them. I've given birth to 3 children, so, and I thought, okay, one on one side of it, and I thought that when I was lying down and they were, about to, and they were my hand, and they were really sweet, really nice people. I thought, on one hand, it's really good because they see me as a human being, yeah? So they're those I'm a woman, nothing different, we are all equal. They are going to do this surgery on me, and they are really nice, and they explain to me, and everything is fine, and I'm fine about it. And then, but then I still thought about that. I thought, wow, they're all gross, and they're big men as well. And then I went, and then I did, because it was fine, everything was great. I saw the gynecologist, and it was great. And I told my husband, I said, you know what, they want me in. there were women up to the operation, and then they were only clothes. And he said, "Oh, you should ask for, you should ask for a woman to be with you." And I said, "No, that doesn't cause me a problem. I'm fine with that. I feel safe." But then I thought, what if I was a young girl? You know, I was 17 having that, and then and what if I had trauma? They didn't ask me about that. I was fine about it, and but and I thought, God, nobody ever, even from the women, they say, "Right, you need to come back straight away tomorrow morning, 7 o'clock." They didn't say, "Will you be okay if they're only men?" Because they'd probably be only men. We don't know the stuff yet, but or do you want some? They never asked, and I thought. But one side is, it's normalized, they're supposed to doing it, and they're specialists, and that's fine, and they're doing their job, and I'm a patient, why not? But then I thought, what if I haven't been okay about that? What if I was really tired and said, "No, I don't want to have this long."
You can ask for it. Yeah, for a
Thinking about it, I thought,
I think it's just important that if when you go for any medical procedure, it is a legal requirement for a shared decision-making conversation about any medical procedure. So you can say, "I want to have a shared decision-making conversation about this," and to put your point. So it is embedded in law that you.
What we're allowed to have. This is here for us. We're not told just.
But the thing is, it's a situation.
Yeah.
I was fine, but my 19 years old, and I didn't even, I thought about saying to her, "Are you okay?" Because they really meant I didn't even think that far, because it's not ingrained, but now it's
I used to find it quite difficult, because just working in the film business, and every time we were doing sex scenes, always had a woman in the room, because you have to protect the female that's there. So I kind of think why isn't it across the medical industry as well? I mean, professionals, it's that. Just have one woman in the room as well, to make sure the nurse and the person, whoever it is a female as well, when there's a woman having an operation or something that's really intimate for professionals and practice.
and it was really wow, and it was super intimate,
And I'm so sorry if you got into it, it's really conversation when I'm
It's good that you're
I just want to say that it was just too kind of painful to point. Obviously, you know much more than we do because you're within the trade. But yes, like you said, women are not they're not seen as special or as different. And in a way, it's good, but in a way, I think we should be a little bit treated this question asked.
Yeah. It's good that you guys have all had this conversation. It's the whole point of this space. I'm not here to talk over you guys or just talk at you. It's all about your personal experiences. And I think your point is very much about advocacy and patients actually standing up for themselves. And that's what I'm hoping with the next generation of physicians, next generation of nurses, these charities like Mortal and Strong, for example, definitely check them out. I'll be talking about their founder in a minute. But they focus on, how do you interact with these healthcare dynamics? How do you actually stand up and speak up for yourself? And if you do feel like your autonomy is being taken away, at what point can you just say, pause, okay, what's going on now? Like Deborah said, you are entitled, and it's a legal requirement to have that shared decision space, that shared decision-making space, starting from primary care, starting from your GP. So if you feel like that's not happening, it's either a case of bringing it up and actually saying, I don't feel like I've been involved in this conversation, or potentially looking at the trust as well and saying, has this happened before? What's been going on? And I think it's very much trust-based and region-based as well. I think I found from personal experience, so I'm originally from London, looking at spaces in London or trusts in London, there are certain trusts that are more focused on the shared decision-making space and give patients more space to talk. There are other trusts which say, this is what's happening to you, let's move forward, essentially. But it's about critically thinking about, do I feel safe in this dynamic? Do I feel in control in this dynamic? So hopefully when we do our roundtable discussion, we'll definitely delve into these topics further.
And again, when I lived in Spain, we had a women's centre just for women to go for their own programs.
Yeah.
And it was just women there. And
which is something I'll be touching on very soon. Yeah, so when we're talking about the history of women, we have to talk about the history of women in medicine. And I may not have time to go over every single woman who has made a contribution to medicine, but we've got some notable examples such as Facilitator, who was a female physician in ancient Egypt. She was one of the first well-known recorded female physicians, all the way up to Elizabeth Garrett Anderson, who was the first woman to receive a medical degree. And so, looking at the span of history, we've seen that women have made such incredible contributions to medicine, not only within gynecological health and reproductive health, which I'll touch on later, but within health as a whole, within the medical field as a whole. So that was a very, very brief history of medicine itself. So now we're bringing it to the current day. So what is the current state of women's health in the UK? So the new Women's Health Strategy was published in April 2026. I've had a conversation with a couple of you about the Women's Health Strategy and how important it's been in terms of driving what we prioritise within women's health within the NHS in the UK. And these are some of the stats that came out of it that I found most shocking. So UK female life expectancy has fallen from 20th to 26th according to the ONET or OECN countries, so countries that have a certain level of development, comparing it to them from 2000 to 2022. Endometriosis, for example, you may have heard of it before, but it's the build-up of lining in certain parts of your reproductive cavity, and it causes intense amounts of pain, especially around periods. That took an average of 9 years to diagnose in women. So 9 years of that pain, 9 years of just not feeling heard. And so that was a big, big priority point when I was looking at this presentation. The idea that there is a huge gap in the time waited for delayed diagnosis and the knock-on effects of that. The life expectancy gap, as I asked earlier in my pop quiz, is 8.4 years between the most and least deprived women in mostly least deprived women in different areas of the UK. Black women were at the highest likelihood of experiencing maternal mortality rates, and that is a whole myriad of issues. I could talk about that for years as well. It's the idea that education hasn't prepped us to look at Black women's health properly. It's the idea that Black women's health is pain management has been under-prioritised and under-institutionalised and undermined for the most part. It's the idea that physical manifestations of ill health, for example, jaundice, which is a liver problem and that causes yellowing of the skin, or cyanosis, which is a lack of oxygen to the skin, cannot be seen on Black women as confidently as white women, for example. So there are so many reasons behind that, and that's a lot of the work I do. But looking at that stat, it just reinvigorated this need to not only address it, but to actually say, what can we do within our education system and what can we do within our patient populations to try and combat that statistic. And then finally, I found another really shocking stat which said that Black babies who are born are 2 times more likely to die in their first year compared to white babies. And the dynamics are very, very similar. It's the idea of education not prepping clinicians and nurses to recognise pathologies on Black skin as well as white skin. So it's that intersectionality that we need to focus on when we look at the women's health strategy, and just the fact that it's not just about gender, it's not just about sex, it's about race, it's about education, it's about diagnoses, it's about treatment, and all of these intersect with one another to provide this life expectancy gap. And a huge trailblazer in this field was Professor Dame Leslie Regan, who I had the privilege of meeting last year at the Medical Women's Federation conference, who was just incredible, and her work and her focus on different areas of the women's health strategy really highlighted what we need to address, not only within the NHS but within the UK as a whole, and as a society as a whole as well. Why do we still have racial inequities between women? Why do we still have socioeconomic inequities between women? And so this is a quote that came from the Women's Health Strategy that I found most relevant to this presentation is, if our approach to health care does not work for all women, so 51% of the population, then simply put, it does not work. And I think we need to take that quote away with us as we end this workshop in a few hours' time. The idea that if this does not work for women who take up statistically the majority of the population, then healthcare is not working for us as a society. And as a medic, as a soon-to-be doctor, for me to actually look at that and go, healthcare doesn't work, actually. Healthcare doesn't work for a lot of women within society. Not to say that it's useless, but for it to say that we are not addressing marginalised and oppressed communities properly and hard to reach communities properly, healthcare does not serve its purpose as serving the health of the nation. And so if we're going to hone this in even more locally, I'm focusing on women's health in Cornwall, and these are three major campaigns / conferences / resources that I found. One being Cornwall's first Women's Health Conference, which focused on access and equity. Deborah herself was a big trailblazer in that conference. And when we talked about it, you brought my attention to this topic. I didn't know it was happening, so it was really important that you actually said, no, a conference has been had to talk about women's health within Cornwall. It was known as In the Future of Women's Health, Access, Equity and Action, with over 100 attendees. These spanned from clinicians to experts to community voices, and it impacted all sectors of inequalities for women, that being mental health, intersectionality, barriers for vulnerable communities or underserved communities, such as, for example, the Gypsy and Romani community, and it highlighted those overlooked disparities in things like cardiovascular health. We didn't just focus on reproductive health, or the idea that women can be reduced to just reproductive health, which is a topic I will cover later. It then used the Your Voice, Your Table, Our Strategy approach to co-design solutions to try and deliver and impact women's inequalities within Cornwall itself. So, an incredible conference. Definitely read up about it and read up on what's already being done within ICBs and within trusts within Cornwall to try and impact these inequalities. Did I do the conference justice?
Yeah.
Perfect. I then did a bit more reading when it came to women's health hubs, for example. So someone mentioned that there were women's health hubs in Spain, a lot of European countries, for example. There are some in Cornwall as well. So they're integrated life course care. So it focuses on the women not only as a pathology or an illness, but as a human, as a whole, holistically. And it provides access for underserved communities in safe, community-minded spaces and clinics. And this is just for women, just to identify underlying issues that may contribute to things like mental health concerns, eating disorders, and other pathologies as well. So not just focusing, again, women as a singular illness or a pathology, but them as a whole, and how we can, as a community, impact a women's health as a whole. So, for example, I mentioned the statistic about endometriosis having a 9-year diagnosis. I can't even imagine what kind of mental health mental health consequences that can have on a woman, what kind of consequences it will have on their interactions with healthcare, what kind of consequences it will have on health as a whole. Would they be able to recognize another pathology on themselves that wasn't endometriosis? Would they be able to actually stand up and say, this is something going wrong with me. I want to diagnose this now and I want it quickly. They've had to wait 9 years. So these health hubs create that space of empowerment and actually say, your feelings are incredibly valid, your experiences are incredibly valid. And as a result, more health hubs are trying to be built around Cornwall itself. For example, at the hospital, there is a women in health one hub, but a women in health community and building that's being built right next to the hospital itself. So again, it's showing that there is real promise in hubs like this, and its impact on the population. They're trying to integrate better IT systems to make sure that we are aligning with those 3 shifts that the former Health Secretary West Streeting was trying to implement, the idea of going from analogue to digital, the idea of expanding hub locations, so bringing these communities and clinics into spaces that can be reached before, and creating strong links with dermatological services. So it means that these hubs don't work as silos, but work with one another, work in collaboration with one another, and truly impact the communities that they are promising to serve. Yeah.
We definitely need to read more about it, and yeah, it's really weird that they exist, but it also makes me think of that quote of 50% of health, if it doesn't work for women, then it doesn't work, and the fact that you always need specific health for women's spaces means that then the health other spaces aren't inclusive of. Well, it always feels like an oxymoron or something.
Yeah, can I just clarify something about women's hubs? So the women's hubs at the moment are aimed for women with greater levels of complexity around menopause, around menstrual health, around it has quite a heavy gynecological focus at the moment. and it is for women because there's this also a focus on the upskilling of health professionals across primary care to ensure that women do get better treatment. So we have done a training needs analysis across primary care to see what training professionals need in women's health and how skilled they do feel or don't feel. So the women's health at the moment are only interested in quite specialist support. We are reviewing the model, or I'm reviewing the model of the women's health hubs at the moment because they're not reaching as many people as I wanted them to reach. However, we also don't want to do exactly what we said, which is take skills away from other health professionals. But there are some women who run a women-only space, so they have trauma and they can't see by men, and so those women's hubs are really important for those women. But also, we'll be working with bringing obstetricians out of the hospital to work in those women's hubs as well, so clinicians across primary care will be able to come into the women's hubs and work alongside them. So hopefully there's like a trickling out of skills where people become more informed about women's health. What I will say, it's the beginning. Like it's a very long journey before you. Yeah. But it's not perfect yet. We've had very big focus on making sure there's longer appointment times because you can't talk about this in 10 minutes to GP. So the appointments are from 20 to 30 minutes, and that's made a big difference. I think we have a focus on women in homelessness, women with disabilities, and women who are the gypsy trucks, so women who are called sex workers, women who are not really receiving any services at the moment. We've tried to support them first as well. So yeah, it's not perfect yet, but it's growing.
Brilliant. Thank you. And that's why I think it's so important for you to be here today, to just highlight why the community health hubs in Cornwall are so important. Again, it's about that continuity of care as well. Like you said, it's about treating women who have those complex cases, but have that multidisciplinary type approach to medicine as a whole. So, like you said, if you start off in a certain area, if you start off with these projects and see how impactful they can be, hopefully they can trickle into more institutionalized, more systemic levels of care as well. So now moving on to our next topic. So we've talked about women's health within the UK, we've talked about it within Cornwall, we've given a bit of a history about it as well. We're now focusing on specific sectors of women's health that have either been overrepresented or underrepresented. So my question to you is, what is bikini medicine? You might have seen it before, you might have heard of it before. Does anybody have any idea what it is?
Well, the quote's really good.
Yeah, the quote kind of gives it away.
That's not the only areas that medicine sort of cover on the body.
Yes, so for the most part. No, that's exactly it. It's the idea that women's health has been reduced to just our reproductive organs and our breasts. Again, not to say that this happens everywhere around the world or everywhere around the country. There are many, many institutions that do focus on women's health as health that impacts women, not just reproductive health. But for the most part, there has been a cultural focus and a societal focus, as well as a clinical focus on just bikini medicine. And I thought this shop window, I think this is somewhere in Italy, I think, from what I know. I might be wrong if anybody does know where this picture is from, but Italy or Spain, where they essentially said that women's health research and focus is fully on just what covers their bikinis. And from a gynecological perspective, I know a lot of gynecological consultants who potentially argue the contrary and say, no, there isn't enough being done on gynecological/reproductive health. However, when looking at research, which I'll focus on later, it does show that a vast majority is overrepresented when it comes to reproductive health and breast health when we're talking about women. And so, just a very quick definition, bikini medicine refers to the misconception that women's health differences are limited to their reproductive organs and their breasts. So it essentially reduces women not as humans, but as essentially just vessels to have these reproductive organs and these breasts. The Beyond Bikini Medicine movement, it was a big movement that at least started in the UK, but actually highlighted through clothing how sex and gender across all areas of health and research needed to accurately reflect the complexity of women's health and the complexity of anyone's health, rather than just looking at it through a reproductive or a gynecological lens. So it included things like the menopause, it included things like contraception and menstrual cycles as a way that impacted treatment efficiency, and the fact that we use these big three, I would say, to influence how we treat women, not just as biological humans who have other organs apart from their reproductive organs on their breasts, but as women as a whole, as a human. So I think the Beyond Bikini movement was a pivotal moment when it came to women's health, to actually say, no, we're not going to be reduced to this certain idea of what a woman is. We're actually going to address how the intersectionality of menstrual cycles and contraception and menopause impact how we treat women within healthcare. The George Institute came out with an incredible study, opinion piece, which highlighted the shift of research focusing from bikini medicine to what's actually impacting women. So when we think about bikini medicine as well, it also creates an additional issue of just viewing women's health as, let's say cervical cancer is the biggest killer of women, or breast cancer is the biggest killer of women. But actually, there are so many other issues that women are facing at the moment, which are on the rise, potentially due to lifestyle, potentially due to pollution rates, potentially due to dietary patterns that impact women, that expand far from just reproductive organs. So things like cardiovascular disease, so CVD, infectious diseases, and MSK, so musculoskeletal disorders like osteoarthritis and rheumatoid arthritis. These are key neglected areas when we're talking about women's health. This research in itself found that out of 44% of published topics, they focused on women's health and reproductive health. Out of this 44%, it was a main focus on reproductive health when looking at women's health studies. It brought attention to the fact that this has increased from 2010 to 2020. The reasons for that can be, they can be expansive. It could either be because there's more funding around women's health, maybe because of social media input and societal calls for things like cervical and breast cancer awareness, but it was found to have increased between the 10 years. It also found that not only is reproductive health sometimes overrepresented within women's health, but it also highlighted that menopause and later life women's health actually received less attention. So it showed that women within reproductive years were the main focus of women's health research, which tells you a lot about how we're valuing women within society in itself. Without me sounding too much like an advocate, I think it very much does give a litmus test for how we view women within society. The fact that our main research is focused on reproductive health and not early years health or menopause, it shows that most of our value and most of our focus would be on how useful women are for reproductive purpose and their status. And I think that's a really, really big gap that we need to address within medicine as a whole. And just the fact that within medical education, I see that time and time again. I've seen that within my own curriculum, that when we talk about women's health, it is mainly focused on reproductive pathologies. It does just highlight to you again and again systematically that women's health can be reduced to just their reproductive organs. And so again, it shows that there is a mismatch between the priorities that are faced by research and within medicine and the actual burden of disease of women. So we've seen with these health hubs, for example, you've got such a complex issue when it comes to women's health, where you've got so many different things you need to focus on, but actually reducing it down to just reproductive health and just whittling it down to just a specific area of medicine is not helpful for women, and can actually cause harm on the long term. And so, as I know time is ticking, I will quickly move on to pain management. So this is another huge area of women's health that has been talked about more and more, especially with campaigns such as the Nurofen See My Pain campaign, which focuses on the systemic underrepresentation and undermining of women's health and undermining of pain within women's health. It's been found in studies that women experience chronic pain more, but receive poorer pain management. So they're more likely to be prescribed sedatives rather than analgesics. So sedatives have a higher rate of side effects or adverse side effects compared to analgesics, which would be things like paracetamol and ibuprofen, and they wait longer for pain relief. This gap can be found to be even higher between women of different ethnic minority groups. So, for example, if you've got a black woman or a brown woman asking for pain relief, they're more likely to wait longer than, for example, if a white woman asks for pain relief. However, even between men and women themselves, women have to wait longer for pain relief. There's a high risk of misdiagnoses, as we've seen as well. So the pain from a heart attack can present differently on a woman compared to a man, and as a result, you've got this reduction of what it means to have a heart attack in women and having these sex-based symptom differences not being fully acknowledged and not being educated on in our future populations means that mismatch and those gaps become even more prevalent. While 70% of chronic pain patients are women, most of the research focuses on male subjects, and we've seen this time and time again within research. And it means that we have gaps in understanding of specific pain mechanisms and treatment responses, which I'll focus on here. So what I mean by specific sex-based pain mechanisms is hormones, for example, such as estrogen, progesterone, and testosterone actually influence how we feel pain, and it influences the intensity and potentially the unpleasantness of pain. So, for example, dysmenorrhea, which in painful periods you may have experienced and you may know someone who's experienced them, actually leads to changes in pain sensitivity as well as brain processing of these pain pathways, and increases the risk of stress hormones being high, so cortisol levels, for example. It all leads to this bigger phenomenon called weathering, which some people may know about or some people may not know about, but it's usually talked about within the context of the pain paths, which I'll focus on in a minute. But it shows an example of how you've got big companies like pharmaceutical companies actually acknowledging the differences between gender-based pain and the gaps between men and women when describing their pain. I think a big part of the See My Pain campaign, which stood out to me, was the use of real women's stories. So if you navigate the webpage itself, you'll see that there are so many testimonials of women feeling like they were undermined and undervalued, and their experiences were brushed under the carpet when they interacted with primary and secondary care settings. There's a big phenomenon called Mrs. Beebe or Mrs. Begum syndrome, which actually impacts South Asian women, where if they go into a primary care setting, they're more likely to be undermined and underdiagnosed because of the conglomerate of different assumptions made about them just being from a South Asian background. So again, that phenomenon still happens in things like pain relief or pain management. And that's why I think the real women's stories, I think this campaign should be taught to every medical school and every nursing school and every healthcare school, just about the idea that real women's experiences and real lived experiences should be determining our clinical pathways and should be determining how we view patients. It shouldn't be based solely on research that for the most part is incredibly biased and incredibly skewed towards male perspectives. It needs to be based on real life experiences. And just a quick look at the pain path itself. I annotated certain parts of it, which I found really interesting. So the use of pain words, for example, I think this is incredibly prevalent, especially within different cultural contexts. For example, if English isn't your first language, you may be assigned to a box as to how you describe your pain. It can either be throbbing, it could either be sharp, it could be aching, it could be dull. But if English isn't your first language and you have other words you need to use to describe it, the pain path actually allows you to do that, adding in your own pain descriptors, which I think is really cool. Then you've got the calendar, which actually tracks how much you're experiencing that pain. We usually see within healthcare dynamics that patients who potentially who share their pain experience but then don't have specific dates as to why it happens, unfortunately, unfortunately, clinicians and nurses and other allied healthcare professionals are less likely to take it seriously. So actually having a calendar there saying, I'm experiencing pain on this day, which shouldn't be the case. I think it should be the case that patients are treated equally, that their pain is understood and appreciated equally. However, when you have that evidence behind you as well, you're more likely within systems that are based on evidence to be listened to. And then you've got prompts as well. So there's a PASS acronym, which is pause conversation, ask questions for clarity, speak up and seek another opinion, which all form the basis of patient advocacy. It's reminded that in things to remember at your appointments, so prompts to stimulate conversations, ways in which you can walk into that room and actually go, no, this is what my pain looks like. You need to listen to me. as well as well as looking at this pain path, I am very, very acutely aware that it is a very naive perspective to just go, this will work, this will solve pain management inequalities between men and women, because not only do you need to have patients actively getting involved in using the pain path, but you need clinicians to take this pain path seriously as well. So what I think is really important is spaces like this. I think potentially we should set up something like a petition, set up something like a report to share with education communities and educational establishments, saying tools like this are really important. Tools like this means that patients feel empowered. And it's all very well that you say, yeah, we've got this pain pass, but if doctors and nurses and AHPs aren't using it and aren't valuing it, then there's no point in using a pass like this. It's another way for patients to add to their workload when they're already in a lot of pain. So that's my personal opinion, but I think it's really important that we have something like this present, and it's readily available, it's free to use. And again, it highlights what kind of shifts we're seeing within women's health and pain management, that you've got bigger pharmaceutical companies finally acknowledging them. And now moving on to gender differences in CPR rates. Before I move on to this, does anybody have any questions about what I've talked about bikini medicine or pain management?
Pain management, what you just had previously, I think that would work really well as a template for lots of women's issues. Actually, I know this is specifically about pain, but this would be a really good template for them to, for women to be able to replicate themselves.
Definitely. I think resources like this are becoming more and more common, thankfully, but it's just about getting people to firstly acknowledge that they exist, and secondly to get patients involved in it, and thirdly to get clinicians to value these tools. So for example, on my website, you may or may not come across it, I also have prompts that try and guide conversations around skin conditions. And for example, if you're from if you have black or brown skin, the way in which your skin presents, let's say for example, eczema, is different from how it presents in white skin. And so I have my own section which allows people to describe pain in their own ways, or describe the condition in their own ways, as well as things to prompt them by. And having that conversation with patients as well as clinicians and saying, this is what we need to guide our conversations, has been overall positive. It's just a case of getting it in education systems and actually normalizing it within them. So yeah, I think you're completely correct. I think tools like this can be really, really, really useful. So focusing on gender differences itself in CPR, I am acutely aware of how much time we have left. How much time do we have? Oh, that's all right. I've just checked the time on my phone, so that's all right.
It's 11:05.
11:05. Okay, perfect. We have time. So we're looking at CPR rates. CPR rates in general. So this was actually mentioned in the pop quiz section at the start of my presentation, but as we know, women are less likely to receive bystander CPR compared to men. They are 68%, the likelihood of them receiving bystander training is 68% compared to the 73% of men. And as a result, there are lower survival rates at every stage of out-of-hospital cardiac arrest care. I think that's really, really, really harrowing to read. Not only to read, but to actually just see within healthcare as a whole and see that it's actually been just accepted. The fact that women are more likely to die if they have cardiac arrest because of their anatomy, and that's what I'll be focusing on. So there are multiple reasons why women are less likely to experience effective emergency care when it comes to cardiac arrest situations. A cardiac arrest is when your heart basically stops beating, it stops providing blood, around the body, and as a result, oxygen is not circulating, which means that you can go into an arrest. The survival admission to hospital admission is 34% in women compared to 37% in men. The 3% doesn't seem like a lot, but when you translate it to survival from admission to discharge, so admission into the hospital up until the end of their care, there's a 37% survival rate in women and a 55% survival rate in men. So the gap gets so much bigger when we're talking about interacting with healthcare settings even more. A major contributing factor to this is, firstly, a poor recognition of cardiac arrest in women. As we spoke about earlier, for example, heart attacks and cardiac arrest can present differently in women. It may not be that central crushing pain that you're told about within lectures or within textbooks or on TV that radiates to the left part of your shoulder. It could be back pain, it could be stomach pain, it could be feeling nauseous, it could even be headaches. I was told by a couple of clinicians that extended hiccups for more than, I think, 3 days could potentially be a sign of a heart attack in women. So there are so many in medicine's eyes, abnormal patterns of recognition when it comes to women experiencing heart attacks. So making sure that we categorize it not as abnormal, but as normal just for women is really, really important. Another huge contributing factor is the idea that we have breasts, and people are scared of doing CPR on women because they have breasts. You may have interacted with resuscitate Annie dolls in the past, or you may have done CPR course. How many of those mannequins actually include breasts? None, exactly. It's all on a male torso. So when you're taught again and again, this is how you deliver CPR on a male torso. When you see a female torso, it's within our human psyche to not recognize something that we've seen before. And so as a result, people are less likely to give CPR to women purely for their anatomy, which I think is one of the most tragic parts of the CPR differences. A third big factor is the idea of cutting your bra, which is what I'll be focusing on next. By St. John's Ambulance, they created a CPR bra campaign which said it's okay to save my life. There were bras that were created to essentially tell people and really walk people through giving CPR to women, which I think, it's a step in the right direction because it means that we're acknowledging differences between CPR rates in women. But the fact that we have to hold people's hands to say, this is how you do it for women, I think shows that there's a failure in the education system when it comes to CPR and first aid training. It's one of the mannequins that we're using. So the bras themselves show you where to compress. It gives you the 3 C's, check, pull, and compress. It gives you a line to cut to use the defibrillator, which is a major reason why people don't give CPR. So 1 in 3 people are reluctant to give women CPR, purely because of the embarrassment of cutting someone's bra. However, the message on the bra says it's okay to save my life. So if you feel like you need to cut someone's bra in order to expose them, to give them that defib pads, in order to give them that CPR, it's so much, the outcome is so much better than letting a woman suffer and letting them experience these huge disparities in mortality rates between men and women when it comes to cardiac arrest. The bra campaign was launched in 2024, so again, incredibly recently, and it was a huge success. As a result, you had different community trusts actually delivering this training to their communities. So the initiative, the hashtag bra off defib on campaign, which was launched in 2022, so before the CPR bra campaign by St. John's Ambulance, actually found that there were campaigns used to normalise bra removal so defibrillators can be used efficiently. This happened in Worthing Hospital and in their community trust, and it was led by Sally Holmes, who delivered CPR training to increase public confidence. She ended up training over 1,100 people only in 2025, which is incredible, and it's helped reduce inequalities in emergency care. Campaigners like Jenny Legg also stressed that bra removal should not be a barrier to life-saving treatment, as we know this. One really interesting thing I found about this picture is, can you spot any men? No. And when I looked at these images, I had 2 minds about it. On one hand, I was really excited and encouraged and empowered. And I thought, we've got more people talking about the fact that we need to deliver this life-saving care to women, and we don't need to have the embarrassment of cutting off a bra or putting hands on the chest or area to deliver that life-saving care. But on the other hand, all of the pictures were full of women and no men. And I think that's a huge gap that we're not addressing itself. I mentioned it to a couple of members before the workshop happened, but the fact that we haven't trained men properly to provide this CPR to women with this anatomy means that, God forbid a case where it was just men around and a woman was having a cardiovascular event, what would happen? And so we're having those simulated scenarios, having those models being used by men, you're having resuscitate Annie dolls with breasts, normalizing or utilizing men and women receiving emergency care is so important. And I think taking anything away from this workshop should be have these conversations more with men. I have my partner is a male, and he's a medic as well. And he grew up around women, but that was the only reason he knows how stark the differences are between emergency care between men and women. What about the men that don't particularly interact with they don't have female relatives, they don't interact with huge amounts of women? What about the men that are actually providing emergency care, who get too embarrassed to take off a bra? They don't actually know what cardiac arrest look like in women. We need to start targeting those men in these campaigns. Does anybody have any questions before I move on?
You don't have this bit of funding for selling homes to deliver the CPR. There should be funding for men to also train and deliver that for women as well.
Yeah, definitely. I think, I'm saying this from my personal perspective in medical school, but we have men and women obviously training in the same room when it comes to emergency care. But again, the models that we're using just use a male torso. So it's all very well having men in the room, but if we're not using female anatomy correctly and accurately within our training, there's really no point in having campaigns like this, because it means that we're not fully addressing the differences in gender. I think, a huge barrier, like I said again, is the idea of not taking bras off and actually using scissors to take bras off. And the fact that loads of people haven't physically done that themselves means that when you're actually in an emergency situation, you don't know what to do because you haven't experienced it. And I think that goes to members of the public as well as clinicians as well. The fact that we've given this trust, we've provided this trust to clinicians to provide life-saving care, but you still have these barriers means that education needs to be changed.
Sorry.
Yeah.
Sorry, go on. I didn't even ask, do you have to take a bra or do you need to defibrillate it?
For the most part, yeah, just because it's like that's where you need to place it.
It would be really good to actually do that as a prevent.
Yes.
In the like, if it's just unchecking bra rather than
Yes.
kind of value.
Yeah.
But that should be part of the first aid course.
Yeah.
You don't actually need to do that.
Yeah, no, 100%. I mean, there 100% you're correct. I mean, there are so many life-saving, first aid courses in the States, for example, that actually teach people to cut the bra itself. And unfortunately, you're going to have to deal with a broken bra later on down the line. So I'd rather have a
unchecking from.
Yeah.
Absolutely safe.
But I was about to say, it's great to hear you because, like you said, in an emergency, you can learn lots of stuff. But when you're in an emergency, you don't think the same. So if you haven't, you've learned the CPR and on a bare breast, on a mountain with a bare breast, you still haven't learned the time you take off. Yeah, it's still to be from this area because I don't know if I'm special or not, but if I hadn't done it, you give me a woman that is on the floor, and obviously I'm a woman, but I haven't worked with those I just want to go there all the time. Yeah. I didn't think, maybe I should, you know what I mean? Yeah. So it's still empowering what you say, because, let's learn CPR on a bra, on a woman, but on another thing with a bra. So you know what to do in an emergency.
Exactly.
Yes.
Anyway, we've done the training, having a mannequin with women with breasts.
So in this scenario here, I think there were a couple of models that we used. So you can see the models there. I've made it very, very blurry. Some of the models were men, some of the models were women, but the most part was cutting off the bra, so I think they didn't have female models. It was just they put the bra on men.
It's different as well because the boobs are in, it's not just the bra, there's actual boobs, they're watching the bra, the boobs don't exist anymore, so.
Yeah. So in terms of placement, you can put basically the defib pads need to be put underneath the boobs and on top of the boob.
Okay.
The issue with bras is that because it's literally in your bra line, you can't put the defib pads
So
on.
I was just thinking if they was actually given a female model to work on, which would be the whole point. Really.
Yeah. So I think they did use a couple of female models, but again, there aren't many being manufactured, so it's.
Then it's going on and
Does anybody else have any questions or? So moving on to our final topic, thank you so much for bearing with me. There's a lot to cover with these topics, but in the spirit of IWN and just the fact that women don't come in a certain colour or a certain shape or a certain size or a certain background, we're talking about women's health in diverse cultural and socioeconomic backgrounds. So there was an incredibly useful article that I would definitely recommend everybody else read as well, which was funded by the King's Fund, called The Health of Women from Ethnic Minority Groups in England. And it just gave a really good comparative study of what women's health looked like for ethnic minority backgrounds. Actually, there was some really interesting stats that came from it. So it found that second generation UK-born immigrants, so for example, me, I'm a second generation immigrant. I was born here, whereas my mum wasn't. And ethnic minority migrant groups actually didn't have as much of a gap between mortality. The way where mortality started rising was due to environmental and behavioural changes that resulted from things like cultural assimilation, whether English was your first language, whether you could interact with your healthcare system correctly, whether your socioeconomic and cultural background meant that you even recognised certain pathologies correctly. So many reasons why the mortality gap shifted, but that was a big factor behind it. It also found that South Asian and Black women had a higher experience of preventable conditions and had higher rates of maternal mortality. So preventable conditions would include things like cardiovascular risk caused by dietary lifestyles or by dietary patterns or lifestyle choices. And so education surrounding diets, for example, education surrounding the metabolic rates of Black women and South Asian women were being underrepresented. So as a result, you have a higher burden of disease. Healthcare outcomes, as we know, are shaped by socioeconomic behaviours, and wider determinants of health differ significantly amongst ethnic minority groups. I think this point in itself is quite self-explanatory, but I think it harkens back to a bigger issue about community-focused health hubs and community-focused initiatives and interactions with health and groups. I'm originally from Croydon, which has an incredibly high ethnic minority population within London. We've got healthcare spaces that go into places like mosques, like synagogues, like churches, temples, for example, to actually talk about these healthcare inequalities, actually coming to the populations that they're trying to serve, not making people come out of their safe spaces, which I thought was really, really important. I'd definitely like to see more of it in Cornwall as well, where the population in Cornwall is majority from a white Anglo-Saxon background. But what's really interesting is that the community focus within Cornwall is unique, and it's different from different regions within the UK. So actually honing in on that and actually saying to migrant populations, underserved populations, populations from low socioeconomic backgrounds, come to these hubs, come to these spaces, and we'll understand what your lived experience is really important. And then lastly, you've got policymakers, ICBs, so integrated care boards and local partners having an important role to play. We know that again and again, but I think having that interaction between top-down and bottom-up change is so important. I spoke to someone recently when I was on my elective who said change doesn't occur just from one way up or one way down. It needs to be a constant flow of movement. And so whether that's through talking to policymakers, whether that's going to your ICB meetings, whether that's talking to local community voices and partners, or even having a conversation with fellow patients and saying, this needs to change. You know, change happens in numbers, and change happens when someone actually speaks out as well. And I'd love to see more educational institutions taking on that change through community hubs, through community mindsets. I'm trying to do that at the moment at my university, where I'm working with Mortal Strong, which is the charity based on empowerment and advocacy for women. And I'm trying to get them to come in and actually have women share their lived experiences around chronic conditions and complex cases for early medics to actually say, this is not what a singular patient looks like. This is not what a singular woman looks like. This is how you treat people as a whole, not just as a singular pathology or as a singular gender or as like we said earlier with bikini medicine, as someone who's just a vessel for reproductive organs. They are a human being. And so these are some policy suggestions as well. Oh, hopefully that will load. There we go. From the Royal College of Obstetrics and Gynecology, I had a read of this. It wasn't the most interesting read, but I think the policy suggestions that came out of it, again, spoke to what I'm talking about now. It requires that cross-government, cross-community collaboration, not just focusing on ICBs, or not just focusing on medics, or not just focusing on community nurses, but focusing on everyone within a community to try and reduce inequalities by co-producing and having culturally competent services that actually say, let's use data, let's use evidence, let's use lived experience to try and drive what we're looking at here. It was also really important to understand how maternity and reproductive care within certain communities were underserved in certain groups because of their cultural background. So, like I said earlier, I'm from a South Asian background where in Pakistan you don't even use the word breast, or when you want to say breast cancer or something, you just say chest. And so, conditions like menopause, for example, in Urdu communities, there isn't a specific word for menopause. It's just an array of symptoms. So actually acknowledging these cultural differences when we're working with our communities increases inclusive research, but also creates a next generation of evidence and sustainability for future physicians, for future communities, and for future women. And so just to finish off this, the presentation part of my workshop, I've got a few book recommendations. This is a good friend of mine, Dr. Liz Murray, who created the book Not Just Painful Periods very, very recently. Her book launch only was around a month ago. And she herself experienced endometriosis. She's a doctor by trade. but she has been a patient in multiple different contexts. So she's seen what healthcare looks like as a doctor and as a patient, and her work alongside her charity, Muslim Strong, has been incredible in terms of enlightening me about patient empowerment and about standing up for yourself within the healthcare system. So if you want a good book to read, go for that. There's also Unwell Women, which you may have come across in the past, but it focuses more on the history behind healthcare inequalities between women, the idea of race and class playing a huge role in how we see women, and the idea, like I mentioned earlier, of hysteria actually impacting how we treat women is really, really interesting. So definitely give that a read as well. And that was the end of my presentation, but we'll be going on to our group discussion in around 5 minutes. In the meantime, if anybody has any questions, please do either ask now or just stop me when we're going on our bathroom break. But thank you very much.
Feel about holistic medicine around women's healthcare?
I think it's one of the biggest solutions to the inequalities we find in the UK. Holistic healthcare can also include things like social prescribing, for example. And I think that's
a lot of barriers for doctors.
Yeah. I think the issue with holistic healthcare, which I think this is my opinion, this is purely not based on evidence, but this is off the record, but I think because a lot of the onus is being placed on a specific healthcare role, whether that be doctors or community nurses, we don't have enough roles that are encompassing that holistic medicine, for example. So,
you don't want to push it because it's natural and it's not profitable.
Well, no, exactly. And I think when you've got things like social prescribing link workers, for example, in healthcare, in primary care settings.
They have more leeway to be able to say, I recommend this diet and I recommend this formula. So that doctors are not allowed to.
So it's difficult because, for example, link workers work with doctors and nurses to get a better idea of how to impact a patient as a whole. They themselves can't say, this is your prescription, it has to be signed off by the doctor. But I think more education about how they can work together, and without it sounding like very naive and rainbows and fairies, but actually how they can work together and say, okay, they need this amount of, their issue is loneliness, and as a result that they're neglecting their diet and their lifestyle. What should we do within the social context, and what should we do within a community context? Can we get the doctor to sign it off as well? Is the way in which we really effectively encompass holistic medicine.
Yeah.
Holistic medicine itself is also about the complexity of cases as well. So it's not just about having one 5-minute conversation and then never seeing that patient again for a few years. It's about having that constant continuity of care. The way that that's addressed is really, really difficult, and I think there are so many elements of like community care, for example, or bringing groups into the community that can address that. But it's about funding, it's about what people are prioritising at the moment. But I think holistic care is one way to go in terms of addressing all of the inequalities.
I addressed a lot of my own issues, like creating my own skincare, my own remedies, my own tinctures, because I'm just fed up with the doctors.
Yeah.
They're 28 prescriptions.
Yeah, and I think because we have such an industrial lens towards healthcare as well, where it is like,
It's all about money, isn't it?
yeah, it's about money, and it's also just about, there's evidence behind a lot of the drugs that we use, but I think evidence sometimes trumps lived experience.
It would cost a lot less all round if they taught women how to look after themselves holistically.
Yeah, no, I completely agree.
It's not profitable for them, so that's why it's not really encouraged.
I think when it comes to profits, I usually focus on community-based groups. So, for example, I'm working with the Race and Health Observatory for my elective, and they focus on preventative health rather than reactive health.
Yeah.
It's one of the 3 shifts as well, going from just reactive health to preventative health, and it is taking into account holistic care. So, for example, South Asian communities, you've got people who use holistic and homeopathic care from Indian backgrounds, and it's worked for them. And it's worked for them.
Been working for centuries.
Yeah,
They've never been working it out.
Well, yeah, I think this is it speaks to a bigger issue, which I do my own workshop on. But
I think you're going to be changing some things in the future. I can see it happening. I think you're going to be a fantastic force, women.
thank you. I to be honest with you, I think a lot of these spaces are really empowering for me because it makes me go back to my uni and actually go, what are we doing differently? Like, what are we not addressing? What are we addressing? I think it's an idea. There's this idea of medical colonialism, So the idea that, you know, you've got women from certain backgrounds, Afro-Caribbean backgrounds, for example, who have native methods of treating their own health, but because it's,
Everything.
yeah, so many things, like, you know, arthritis, for example, psoriasis, which is huge in the Afro-Caribbean community, they have homeopathic ways of addressing it, but because it doesn't fit within the mold of allopathic Western medicine.
And because it's not a solution long term, it's a little faster, and eventually it will cause more harm than good.
Yeah, and that's
That's
what.
okay. I know you're probably not really allowed to state these things, but I am.
And that's why I want to hear it from you yourself. You know, the idea that education itself shouldn't just be focused on that Western lens, and that's a lot of the work I do. I focus on the decolonial perspective of medicine, the idea that, you know, you don't just focus on that paternalism.
I haven't got any fancy degrees, but I would say that I'm a herbalist.
Yeah,
100%.
yeah, and you don't need a degree. You know, you don't need a degree to say that. It's about your lived experience, and I say that again and again. I would trump lived experience over any evidence really off the record.
If I ever wanted to treat anyone, and if I ever wanted to go down that road, I need about 20 grams to prove that I am viable and that I can, you know,
Yeah.
deliver that kind of care.
I think because we live in the UK as well, because we are, like, you know, there's a lot of red tape, and we are we have been ruled from colonialism, and that is.
I'm going to do it anyway, regardless.
Yeah. I think the issue is that because we have this cultural relativism within the UK and the US of just having a Western Eurocentric perspective, you know, in so many other developing countries, for example, I say developing, but in countries within the global south, for example, like Kenya and Nigeria, you've got people like that who don't have the formal qualifications to say something, but they actually have that lived experience, and people do go to them as community leaders.
Maybe I have to set up my business in a different country, and then once it speaks for itself, we can use it here.
Yeah, I think evidence is a big thing that stops a lot of doctors from taking on board, like, you know, homeopathic remedies, for example, or
It's not evidence proven, it's money. It's because medication is really profitable, and then if you have one medication, you then need to take another medication because it's got side effects, and it goes on and on and on, and then they just have a lot of financial gain.
yeah.
Not the doctors in particular, but the shareholders. And
I think there is this industrial model of care that needs to be addressed, and again, it does focus on that very colonial perspective. So it's really good to hear from you. Yeah.
Just a few points, and then you can talk about and what to do with some of the work. The first thing that so I'm an Arab, so I think because I grew up in Jordan, and in Jordan it's mostly like, you know, gynecologists, mostly men, and that is something that the women are very comfortable with. It's not because that's the case, you know. It's just like there are more gynecologists men or obstetric than females, so it's a common thing, and women usually are comfortable with that. So here I found it difficult that when I try to talk about any women's health issues with male GPs, that I'm just always felt like, you know, being like, oh, it's not about being offered to talk to a female, but I'm like not being able to talk about it because they're like kind of shy about it, you know. I mean, I'm just confident talking about it because all my life I'm talking about it with male doctors, you know, but then I'm having to being put off, you know, or I'm being put off by that because they're just like, oh, I'll put your name on a waiting list, so you talk to a female doctor. I'm like, I didn't understand. I told her that, but that's one thing. It's not like I appreciate it, but also a few times I had to talk to a nurse because it's a female, so I didn't talk to a GP or to a gynecologist. You know what I mean?
Yeah.
The other thing that I struggle with, I don't know if this is, I think this is for all women, regardless of their ethnic background, it's that post-birth issues are very, very neglected. That's how I feel. And it's just being, like, for example,
you need to rest and you need to, it's just like takes time to recover and for your body to recover. But including like sex life, like sex desire or drive after post-birth. And these are really sensitive, like to a point, like the moment you start talking about it with a GP, it's really like, the conversation doesn't last more than, it's not even a minute. It's just like as if it's only related to personal issues or like, whatever your relationship issues or financial issues or that you are really, you're exhausted and you need to recover and give it time. So it's never something that anyone would really follow up on.
Yeah.
It's completely like shut the topic, it's just not,
I think you make some good points. I think speaking to your first point about the choice, whether you can speak to a male GP or a female GP, and sometimes when there aren't any female GPs, you talk to, for example, a nurse, for example. I think it obviously differs practice by practice whether they just have that availability. But like you said, I think just making sure patients have that choice is the most important thing, and not having a choice shoved down your throat and actually saying, no, you can talk to
I
them.
think she's saying that even when she speaks to the right person, she's not uncomfortable. It's not necessarily that she wants someone that man specialised in that specific topic because nurses aren't, and then you can't meet her needs.
I think that's an education issue in itself. Obviously, you can't address that within one session, but I think again, it's an education issue. It's the way that we're teaching doctors. It's the way that we're teaching nurses and male doctors and nurses, whether they're actually properly being taught on women's health or they're just being told this is what you do in a textbook. Just move on after that.
They do eventually get their little Google Bible out now and start reading what your symptoms are and how they're going to treat you. And it's just like, I don't even want to go to the doctors anymore. It's a joke.
No, it's just that honestly, there's like there are some issues that they're not at all. I'm sure I don't know if it's only my experience, but I can say that all women that I know that have given birth, they all had like a lot of issues that they could not, they couldn't discuss freely, or they were not really given the right attention,
And I think the role of people like link workers, for example, social prescribers as well, they hold a really good potential when it comes to things like long-term care after birth, because I think a lot of the research is focused on like the immediate attention, the immediate care, the immediate mortality rates after giving birth, but having that more, continuous community-focused care needs to be delved into more, and I think Deborah can add something as well.
But you're absolutely spot on in what you're saying. There is a massive issue around perinatal health and well-being for women, and it's something that they are trying to address, and there is a lack of understanding and education. There is actually even a 10-week health check for women post-birth isn't being delivered the way it should be, but there is going to be a lot of work happening in Cornwall over the next 12 months around that perinatal period, and one about upskilling people, but also that's something to really want to build into the women's health hubs, that women who are needing support in that period, in that period, that they get it is a high risk time for women. Actually, there's a lot of health issues that arise. The focus is on the baby, and mum gets forgotten. So absolutely right in what you're saying, and across, I'd say every health professional has lack skills in that area. It's easy to feel like we're as new mums, but actually that's not the case at all. So yes, it's pretty crap now, but hopefully it's there's a big focus on improvement in that area. So it's one of the areas in the women's health strategy that we're keen to focus on. So, but with voices of women like you, I think like raising it, like right into ICB, right into GP practices around, it can be really helpful for that change as well.
Can I jump on that? Just say, it really is explain that these services all exist. I had a son coming in, it was awful, for a multitude of reasons. But things like, I was in childhood, you have therapy for your child to birth. I was told this 4 years later, when I had my second child. What I want now is I want to focus on this current pregnancy.
Yeah.
These link services, you just know about the midwife and the health professional. You go over to the health professional 2 days after you came home, and then the next point was 9 weeks online. It was ridiculous.
Yeah.
And what happened with the urge to never ever happen again. Especially like my partner was only allowed to visit for an hour a day. He wasn't a visitor, he was a parent. And that affects the woman as well. No support. There was one in my ward, pain management there I was given this morphine, which means you have to stay there 24 hours, which is going a week later, I'm still there, they were just going to go home. But I think it'd be really good to know about the services that are out there for women.
It almost feels like if some of these things available, but they don't go, how do I know that? Because it would cost a lot of money to support women properly, so they're there, so they know they're there, but we're not going to tell you about them.
The services are there, do you want to help?
They do want us to help, if they're there, then we can't talk about them, we can't.
Not to interrupt everyone, but can I just suggest that we have a 5-minute break, just so that no one can take it. And maybe all lot of emotions and like a lot of things that we can discuss. Just a 5-minute break, is that?
Yeah, the 5 minutes break is fine, and I'll move the chairs around, and then we can have probably we have time for around 15-20 minute discussion because that's all right. And this is me if you want to stay in touch. Yeah. What do you think?
Funding, I heard it from a friend of mine who she said, showing him what they are in us, I think cafe, because I think vision survivors are being able to just have a so that's something I would say, but it's busy.